Okay, give it another minute. Okay, I think we'll get started. Good afternoon, everyone. My name is Dr. Rob Murphy, and I'm the Executive Director here at the Institute for Global Health and the John Philip Fair Professor of Infectious Diseases and Professor of Biomedical Engineering here at Northwestern University's Feinberg School of Medicine. Thank you for taking the time to join us this afternoon for our latest installment in the Institute for Global Health First Friday seminar series. And today's presentation is entitled Decolonizing Global Health Research. Please take a moment to follow us on Facebook and Twitter, hashtag FSM Global Health. In addition, we welcome you to become an Institute for Global Health member. Very easy to do. Just go to the website and sign up. You can also sign up for one of our centers as well as the Institute. You'll have access then to specialized resources and services that support the research infrastructure. And please, for more information, please go to our website, as I mentioned. Today, we're very excited to have Dr. Eugene Richardson join us for a very timely discussion on recent studies that have been conducted that attempt to decolonize global health research. Eugene Richardson is Assistant Professor of Global Health and Social Medicine at Harvard Medical School, as well as Assistant Professor of Medicine in the Division of Global Health Equity at Brigham and Women's Hospital. He received his MD from Cornell and then went to Stanford, where he did his infectious disease training and a simultaneous PhD in anthropology. He knows all the ACTG people that we worked with at Stanford for many years, and we have a lot of things, actually more things in common than I imagined. Anyway, his overall focus is on biosocial approaches to epidemic disease prevention, containment, and treatment in sub-Saharan Africa, primarily West Africa, where we also have a strong position. And as part of this effort, he's chair of the Lancet Commission on Reparations and Redistributive Justice. Previously, Dr. Richardson served as the clinical lead for Partners in Health Ebola response in Congo District, Sierra Leone, where he continues to conduct research on social epidemiology of Ebola virus disease. He also worked as a clinical case manager consultant for WHO's Ebola project in Beni, the Democratic Republic of the Congo. More recently, he was seconded to the Africa CDC to join their COVID-19 response. He's also recently authored Epidemic Illusions, a book about the coloniality of global public health. There's going to be time for questions following the presentation, in which we welcome you to submit questions through the Q&A feature at the bottom right-hand corner of your screen. Now, Eugene, thank you again for coming today, and I turn it over to you.
All right. Thanks so much. It's great to join you today, and looking forward to the discussion afterwards. I'll share some slides. All right. So the topic today is decolonizing global health research, and I put the decolonizing in scare quotes because I'm ambivalent about the term. I think it's the one being used right now. It's the buzzword, and it tries to get at, examining and removing all of the oppressive structures that have essentially transcended independence of former colonies and still continue to exist in political, economic structures, even global health research structures. part of the reason it's problematic is that, and if you're interested in more in-depth analysis, I'll recommend a book review in The Nation by Arjun Appadurai, and where he looks into a book by Walter Mignolo about decoloniality and says that, that term actually means, getting back to something pre-modernity, getting back to something before colonialism. And it really fetishizes indigenous knowledge systems. Whereas someone like Achille Mbembe says, well, no one wants to go back to pre-colonial, nor do we want to stay in this kind of neo-colonial realm. We want an alternative. So some of the theorists argue over, whether the term is appropriate, but I agree with Achille that what we're looking at is an alternative, what combines the best of modernity, but also is able to, have a strong kind of anti-neo-colonial element to it. And so with that in mind, here's my no financial disclosures. I wrote this book and presented it earlier last month at the Health Across Borders conference with Paul Farmer. And this is my exploration of, how coloniality, how these forces that have transcended the independence of former colonies still permeates what we call global health, development, aid, but even what we do in the research realm. And so part of what I try to do in the research realm is to push back against, status quo ways of interpreting the world. And you could think of it as decolonizing, you could think of it as anti-racist, but our goal is to sort of, find new methods, find new ways that take into account oppressive structures that are actually built into research methodologies and open it up so that, new forms of knowledge production can come out of it. So I'll just segue quickly from things I do in the book to 4 research projects that we've done in the past couple of years. In the book, I talk about how I think of mathematical models of disease transmission, so our COVID models, our Ebola models, as merely fables dressed in formal language. Not as outbreak science, as a lot of people think of them as. And I kind of agree with Nassim Taleb in this, is that, if you are dealing with complexity, and that's what, any prediction, any forecasting does, that you always have to distort. You can never, you'll never be objective about, how you forecast. You always have to pick and choose variables, salient ways of interpreting and methods. And so in doing that, you're actually making ethical decisions about which variables to choose because of nonlinearity. You never knew which variables are going to fly out and become geometric. And so there really are ethical decisions. And that's kind of different what we think of as in the physical sciences, right? There's nothing ethical about 3 quarks coming together to make a proton. And so more people realize that there are, ethical decisions to be made when we do things like forecasting, modeling, even regression analyses, because we're choosing variables. Then the idea that we're setting epistemic confines to how people see the world. You basically are choosing these variables based on, sort of pre-held ideological presuppositions. And the book is an exploration of how much of what passes as outbreak science or global public health actually does a lot of neoliberal work. It sets up epistemic confines to the understanding of why some groups live sicker lives than others, confines that sustain predatory accumulation rather than challenge it. And this is the afterword of the book, that it exists as a standalone article in BMJ Global Health. So the book essentially has critiques of causal inference, big data, regression models, and epidemic modeling. One of my favorite papers is this one by Sharon Schwartz. If you want a good exploration of how causal inference is really a conservative methodology at its heart, I would recommend that. But I'll talk quickly about critique of epidemic modeling. Here's a good article in The Nation by Tim Schwab. Do Bill Gates's billions distort public data? I certainly think they do. If we take quickly the IHME, or Institute for Health Metrics and Evaluation forecast from last year, as an example of what I was talking about, you could see that one, they were all wrong. Their predictions fell outside of their 95% interval 70% of the time. But their plunging projections were also used by Trump to say that he was doing a good job. So they were easily co-opted as being ideological. And here's where you can start to see what I'm talking about. That there's not a science to this. That you start with projecting a social imaginary and you run with it. And I will argue that IHME projects a social imaginary that is easily co-opted for neoliberal purposes, but also for racist purposes, because they endorse a future where COVID disparities continue to exist, institutionalized racism is rampant, hyperincarceration is ongoing, and universal health coverage is denied. In short, they actively delimit through their exaggerated precision and acceptance of government interventions as status quo, the public's ability to imagine social alternatives. And the reason I say this is because all they recommend is wear a mask, close down some businesses, stay at home. There are no interventions into risk structure. Why do Black people have 2 to 3 times the incidence of mortality? And if you're not intervening in that with your projections, then they're going to continue. So even if we reduce from 600,000 to 200,000 deaths, there's still 2 to 3 times the deaths in the Black population. And so if we use Ibram Kendi's definition of a racist policy or a racist analysis, which is one that either increases inequalities or continues the status quo, then these could be considered racist analyses because they just continue the status quo. So part of forming our Lancet Commission on Reparations and Redistributive Justice was to see what would imagining social alternatives in our research methodologies look like. And one of our first papers, so I'll kind of go back in time, is an attempt at anti-racist modeling, and it was published in February in Social Science and Medicine, Reparations for American Descendants of People Enslaved in the US and Their Potential Impact on SARS-CoV-2 Transmission. And so I talked about this Ibram Kendi's definition. So the background to this paper was that, as we all know, that Black Americans are suffering significantly disproportionate incidence of COVID-19. And so to go behind the mere tallying of that, the potential for actual racial justice interventions into those disparities has not been adequately explored. And this is the important thing. I think people, when they think of outbreak science, they just think of, okay, we're doing sort of mechanistic computations. And that's not the case, right? Models, they have to make assumptions about how people interact with others, but they rarely account in those interactions. They sort of just the pinball stuff, right? The billiard ball stuff. They rarely account for social forces like institutional cultural racism that structure such interactions. They can therefore obfuscate such forces in their attempts to describe outbreak transmission dynamics. Correct definition of what we meant by reparations: it's an acknowledgement of grievous injustice, redress for the injustice, closure of the grievances held by the group subjected to the injustice. And the group that's leading the section on people, descendants of people enslaved in the US, their program of reparations would be eradication of the wealth gap. And the wealth gap between Black people and white people in the US is $10 trillion. So that 40 million people is $250,000 per person. If that had been paid, so 10 years before the pandemic, we sort of explore what that would look like, the ramifications on current transmission dynamics. So we considered a range of reproductive ratios to back calculate transmission rates for 4 cells of the simplified next generation matrix from which you can calculate R0. We use data from Louisiana because we were able to get good census data on overcrowded housing, good COVID data. And it's also a state where there's mostly Black, mostly white, but there's not other minority populations, more than a few percent, so that we could do this binary analysis. So we modeled the effect that monetary payments as reparations would have had on pre-intervention transmission rates and subsequently are not. And here's our little next generation matrix. And beta's transmission rate, pi's population proportion, here's the recovery rate, and then here's the contact rate here. And the idea is that, so this is kind of the transmission rate in between Black people. And here it is between white people. And, this R naught can come, is kind of dominated, the value of it is dominated by the diagonal or the eigenstructure that of the high risk population, which is currently this one. So if you're able to reduce transmission amongst the highest risk group, you reduce R naught for the group as a whole. And we theorize just by reducing contact rates. So, better housing, less overcrowded housing, ability to social distance, but then also in the, do I have it down here? Also in transmissibility, in that people don't have to be in frontline work as much. They're able to use PPE more, masks, hand sanitizers, that kind of stuff. So here is the evidence of overcrowding by housing. You can see that Black populations have significantly more overcrowded housing by census tract, and it's a simple idea that reparations would just reduce some of this overcrowding to parity, and therefore contact rates could be near parity. Reasoning through the consequences of this increased equity via the matrix transmission models, we demonstrate how a successful program, and reflected in this ratio, could reduce R naught by 31 to 68%. And therefore, the restitutive program would not only decrease COVID risk for the recipients of the wealth distribution, the mitigating effects could be distributed across population at large. So here you have, and here's the ratio. So if transmission rates are 4 to 5 times higher, which is what we calculated in between Black and white populations there, that by just reducing those kind of contact rates to near parity, you don't even have to get to parity, get to around 1.5, you reduce R naught by a significant amount. The mechanisms are by narrowing the path-dependent racial wealth divide. This is the important one, changes in the built environment, fostering the ability to social distance. Frontline work would be spread across racial groups, and then a decreased race-based allostatic load, leading to the excess mortality via comorbidities. And then we concluded, since reparations had not been enacted, reopening American society early had a disproportionate adverse mortality effect on Black people. And we started this paper back last April, so that this was predicted. And so we conclude by saying this appalling evidence of racism embodied as disproportionate COVID-19 should add to, it's just a small part of, there are strong moral, historical, legal arguments for reparations, but this adds a component. This project was to demonstrate to people, how does it look? How do social forces make people sicker? And how do structural interventions work such that, there could be less health inequity? And so that's kind of I want to call it decolonizing research, but attempts at anti-racist research to really show the mechanisms that are behind racist determinants of health inequity, and what interventions, how they might play a role. This was picked up by various news outlets. Here's the article in CNN, and since then we've received loads of hate mail. Loads. And so I was kind of welcomed to the culture wars by publishing this article, and it's something we can talk about. The next article is a bit of a different way of looking at how research can be used to improve global health equity. This was the national COVID sero survey in Sierra Leone that we just put up the preprint this week, and it's under review right now. Via my secondment to the Africa CDC and the fact that I work closely with partners in health in Sierra Leone, we developed a project with the Ministry of Health there to do with what is now essentially the first nationally representative sero survey from an African Union member nation. And here's our team going to one of the islands off the coast. So our primary objective was to define age, sex, specific seroprevalence of COVID-19 in the general population, and then to identify risk factors for seropositivity. Other studies that had been done, there's seroprevalence studies out of Kenya, and I just saw them produced another one, but they use blood donors, so it's not representative. Even though their most recent one, just this week, says that there's a 48% prevalence in Kenya. Other studies looked at healthcare workers, asymptomatic healthcare workers, and then, this was a combined measure. So this one wasn't nationally representative because they only went to 6 of 117 districts. So we thought we'd improve upon these studies by, one, we found a better performing assay with actually 100% sensitivity and specificity, and by enrolling a nationally representative sample. Here's what we did for our power calculations. Basically counted that we need 1,200 households. Here's an interesting thing that it was new to me and maybe not new to any of you. So I'm out in San Francisco now. I'm involved in a project at UCSF for essentially people that are identified as being COVID positive. We get the list of them and then approach their household. And if they have if they're not living alone, we ask them about enrolling the household in a study where we give them a freezer, like one of those little college freezers, and the whole household takes daily nasal swabs, saliva, and stool samples so that we can see what transmission looks like in the household over the next several weeks. You can draw blood every 5 days or so to see, I was actually enrolled in the study myself because my son got infected. I didn't get infected because I was vaccinated, but my wife didn't get infected from him either. This was prior to her being vaccinated. And we're starting to think that it might be because, certain people have T-cell responses that towards other coronaviruses that actually fend off infections such that they don't even seroconvert. But this is all sort of in early stages. But what was interesting to me is when we produced the protocol for this, UCSF said we don't need IRB approval. And I thought, wow, this is crazy. It's invasive, very identifiable stuff. You're bringing people in, family members that don't even have it, to do, semi-invasive samples every day on their own. They said, no, this is public health surveillance. You don't need IRB. And they pushed back very hard. So we don't have IRB approval for it, and we didn't need it. So I thought, well, this is just a sero survey, so same thing would go. And yeah, Harvard said, it's not research, it's public health surveillance. Submitted to Sierra Leone, they wanted to review it, and they gave us IRB approval. So just a quick aside. So Africa CDC supported the project, provided serology kits, budget for field teams, and then we conducted the survey in March. Cross-sectional, what we did was we had Statistics Sierra Leone pick 120 random enumeration areas from around the country, and they're like census tracts. They have 80 to 100 households each. Then we got a big satellite map, or many satellite maps of each of the enumeration areas, looked at the rooftops, numbered the rooftops, and then randomly picked 10 households from each of the enumeration areas, and then picked 1 to 2 persons per household, almost randomly. But because the population, the demographics are that there are so many young people there, if you had just went randomly, you'd oversample the young people. So we had to adjust it a little to get some of the older people. And then we collected finger stick to use in the rapid test. Here's the rapid test, the right sign. You can see 100% combined specificity and sensitivity. This was FDA testing. We then did our own local testing and found the same thing. And it was important to do the local testing, as I had learned from doing Ebola sero surveys, where when we ran negative controls for our Ebola assay antibody for our ELISA, we found that there was zero signal for negative controls in the US and in Europe. But in Sierra Leone, there was a lot of signal. And so we presume that there's, cross-circulating stuff that we don't know about there that, had us raise our threshold. But we didn't find the problem with this kit. Here's the demographic data, but the more important are the real results. And so here's the unweighted seroprevalence. We basically found in some of the outer rural areas, it wasn't quite perfectly random. And so we weighted it by district population, kind of post stratification. And so we found a low overall, only 2.6%, which is interesting, even though it's lower than kind of the sort of estimates of other places on the continent. One of our CDC colleagues said, this is just like the flu that I was chasing 15 years ago, that the last place it showed up was West Africa. especially Sierra Leone and Liberia. And so I'm thinking, what is the dynamic? That same thing with SARS-CoV-2. They're just starting their third wave there, but this is probably one of the lower prevalences in the world. And maybe it's because not a lot of people travel there. They also did a good job. They put all their resources at testing people at the airports instead of really testing their population. So maybe they prevented a lot from coming in. This is what we found. Here's the age distribution. And here is the urban versus rural, which is a finding in most places. Obviously, the urban places, less ability to social distance, closer to international networks, found 4.2%. And this was a significant difference. So 2.6% means that 218,680 people were infected as of March 2021. And although that's small, the huge finding is that this is 43 times higher than their case reports, than what they've actually noticed by active surveillance. So one, it means that herd immunity is far from being reached. And that has allowed us to make some strong recommendations about vaccine equity, which I'll talk about. And so, yeah, although the overall seroprevalence was low compared to Europe and the Americas, this indicates enormous underreporting. This has ramifications for the third wave. So as of the end of June, they were reporting an average of 87 cases per day. But because of what we saw via the underreporting, this means that there actually could be upwards of 4,000 cases per day. And this is in a country with only 0.2% of people fully vaccinated. And so the extrapolation is that maybe this reflects underreporting across the continent. Here we are again. So first wave, second wave, third wave, but we think of these as real hard data. But if you look at, take our underreporting stat, then this is 40 times 40. This is 75 times 40. These graphs look very different as far as what might be considered real numbers. This is 87 times 40. And so these data should strengthen demands for faster vaccine deployments, including support for IP waivers and technology transfers. And they also need to strengthen active surveillance there. It's out in preprint as of this week, and it's under review. How this paper is a little bit different. So, the first paper we smuggled in a lot of social justice, reparations, here are our recommendations. This one was more of your standard kind of seroprevalence paper, but once we knew the results, we knocked out a commentary. So here's another way of doing kind of your anti-colonial, anti-racist work, is that even if you have a more milquetoast presentation of epidemiological data, you can always attach a commentary or put even a commentary in a different journal, as we did in BMJ Global Health, that combines, right, the idea that one, these numbers show that, look at what vaccine inequity is going to do as far as looming mortality in this region. Could be a repeat of India. We also combined our ideas about reparative justice, how, one of our colleagues, Jason Hickel, has calculated that since 1960, the net appropriation of resources from the global south has been $160 trillion. So starting to address that reparatively, this could be the first step in it, setting up this, a vaccine system, and then would have to move on, 100-fold. But here's another example of how to do it, by attaching commentaries that bring into more of the justice issues. Here's another paper that we did during, this was Sierra Leone Ebola outbreak, post-outbreak with survivors. And we were looking at the impact of social support. And how this is kind of a, sort of, there's like a socialist theme here, right? Partners in health, one of Paul's ideas for the work we were doing there was to kind of create a WPA, that every single survivor that came out of a PIH Ebola treatment unit, and this is over 700, was given a job, was employed by Partners in Health. And that didn't happen anywhere else. A couple people would get employed by other NGOs, but mostly they just got the standard kind of bag of rice, bag of oil, some batteries, a flashlight, like a small package. So we wanted to find out, okay, there was a natural experiment that was done, essentially. Some people got a huge amount of social support in the form of employment, some just got the little packages. And we wanted to find out, was there an association between the amount of social support and their well-being 3-4 years down the road? And so here's the papers where I get to incorporate my critical theory on symbolic violence, but through a paper on impact evaluation of social protection. It was quasi-experimental. We enrolled 200 randomly selected survivors in 3 districts. We stratified on 4 levels of social support received, and the substantial one was a job greater than 6 months or this long-term support. We used surveys on well-being adapted from WHO and food security from HFIAS. We did BMI, some in-depth interviews, and then as far as our data analysis, we used the GEE to control for clustering by district. I put this up because, consent in studies in these areas is a very important thing. It's like, how do you translate what you're doing via consent process so that you're not just doing something cursory, so that the people really understand what you're doing? And a lot of our projects in Sierra Leone, since we've been there and we know people, deal with first talking to a sectional chief, talking to a town chief, having palm wine with the town chief, breaking cola nut, having a big meeting of the town, showing exactly what we're going to do, and then going house to house. And that's an important part of kind of, decolonizing the research process. So more consent. Here are our results, and I'll just refer you to the paper for that. What we found was that the social support category 4 was significantly associated, one, with food security 3 years after being, and this is even if they only had 6 months. It's not like they're continuing being employed. It's just, was it, in that vulnerable period, did they receive strong social support? 2 through 4 were significantly associated with higher well-being. Secondary and tertiary education were significantly associated with lower well-being. Loss of work significantly associated with lower well-being, and then having electricity associated with higher well-being. BMI was not associated with social support, but participants with tertiary education had significantly higher BMI. And then males had lower BI compared to females when controlling covariates, but dependent on marital status. Widowed males, higher BMI than single females. The qualitative part, people said we had a sense of purpose during the crisis when we were employed. Work and fellowship helped us cope. We can invest in businesses. So even if employment didn't continue, we saved up some money to then do some petty trading afterwards. We had literacy classes, life skills classes as part of the job, that when families lost breadwinners, that people with jobs were able to take over the role, and it reduced stigma. So in survivors, the level of social support right after they were discharged was significantly associated with improved well-being and food security years down the road. And the idea is that, even short-term support during this vulnerable period post-discharge can pay dividends 2 years later. And so the kind of decoloniality element of this one was, one, to show that, yes, outbreak, NGO, containment is not just about showing up, bringing the clinicians and logisticians, getting people to survive and then discharge home. That outbreak means, and this is what symbolic violence of outbreak means, right? The word itself kind of says, well, when there are no more infections, then there's no more suffering, right? People can move on. But suffering does continue because of all the structural determinants that go along with losing family members, losing livelihood. And so, putting IVs in people in shock, that is as important as, once they're discharged, setting up the social support systems. And we're still there in the country, helping strengthen hospitals as far as the work Partners in Health was doing. The other way that this is sort of a decoloniality example is that, and this is what I like to do. This was a real mixed method study. We used proper qualitative methods and randomization and regressions with GEE. But at the same time, because of the way it was set up, it allowed me to smuggle in a lot of critical theory and Bourdieusian theories of symbolic violence into the paper. So although it's kind of put out there for a more kind of global health practitioner audience, those that will read it will see that I've used it as a vehicle to kind of smuggle in what would normally be an esoteric paper in sort of medicine anthropology and theory, which, hardly anybody reads. So that's another way of doing it. You have the, you want to get your critical theory, your critical race theory into papers. You can do it via sort of ones that present more mainstream methods, and then you kind of smuggle it in via the discussion and the introduction. And then I think this is the last one, a paper I did when I was a ID fellow. Okay, about 10 minutes. And this was on, so I was working for the Desmond Tutu HIV Foundation in South Africa with Robin Wood and Linda Gale Becker. The idea of this paper was that, TB rates in South Africa had been on the rise even before HIV came along. So, it's like, what can we wanted to think of what was a non-HIV explanation for the huge epidemic that was there. And we felt that, it has obviously, because of the way TB works, it has, something to do with either the built environment, how people are living, or even how they're commuting. And so what we developed with some of the people from the engineering school was this portable logger that measures CO2 concentration, temperature, humidity, and GPS coordinates. And then we recruited, let's see, this paper was about, the school. So we recruited students at this school and had them wear them in their backpacks, and then, log through their day. We could see where they were via the GPS coordinates and the time. And then we could also see what concentration of CO2 they were breathing. And so you look at these, and these are probably some well-ventilated classrooms. C, they were outside. So you can see it's actually down around 400, which is the outside value. But then E and F must not have windows because they're breathing at 2000. That's very high. And what we did with some of these equations and variables was essentially to use the level, the parts per million of CO2 that you're breathing in as kind of a surrogate for how many liters, or how many rebreathed liters of other people's air that you have coming in, and then using that as a surrogate for your risk for TB. And so, obviously these people in these rooms, if you introduce a single person with TB, have a very higher chance of getting it than in other places, because the evidence is that they're rebreathing in a lot of other people's air. And essentially what we found is, that the places without ventilation are increase your risk of getting TB. And we tried to quantify how much of a risk that was. And the practical recommendations from this were recommendations that people knew 100 years ago. And this is what we thought was going on, that 100 years ago, when we didn't have cures for TB, we did things like this, where there were these open air schools, or that giant windows were the way to go about it. And once we got the TB meds, buildings and schools started looking a lot less like this. And so the idea is that ventilation is still a huge component of how we can prevent TB, and it should be thought of when you're building. And so that was the idea behind this, the hospital. So we have a lot of people that are interested in TB and Partners in Health. And when Butaro was built in Rwanda, they kept those old school mechanisms in mind. So giant windows, and then this fan, this big ass fan. And it's kind of funny, but that is the name of the company, BAF, Big Ass Fans. And they're actually doing quite well for themselves. So the idea, we had a follow-up study which essentially traced. We gave the same loggers to people that were commuting from an hour, 2 hours outside of Cape Town into the city to work. And essentially what we showed was that those people that are 2 hours outside of Cape Town used to live in the municipal area, but because of forced removals and apartheid, they were forcibly removed to these places. And now that's manifest in these commutes where they're put at risk. And we showed how in the mini taxis and the trains, how high the CO2 concentrations were, such that we thought that maybe 15% of the TB outbreak in Cape Town is attributable to just those commutes. And so tracing a current outbreak to socio-historical forces that set up the foundations for that risk was the goal of the project. And that's how you can, that's essentially, again, the word is problematic, decolonizing. It's anti-racist, it's anti-apartheid. It's to show that apartheid just didn't have its risk in impoverishing people, in creating a horrible racist system and killing people with physical violence. It also killed people slowly through epidemic disease, whether it was bringing people to the mines, working there, putting them at risk, and then sending them home to infect their home villages, or forcibly removing them. And then decades later, they're forced to go on commutes that put them at higher risk. And so part of the results of that study, you can't immediately solve the forced removals, but you can put stickers up in the cars to, open window, or in the vehicles to open windows to reduce TB risk while you're working on anti-apartheid reparative justice. And so we are working on that. One of our commissioners that leads the section for South Africa is working on the reparations for apartheid are not monetary like they, I talked about for descendants of people enslaved in the US. It's land reform. So doing something similar to what happened in Zimbabwe, which kind of failed, taking the land from white farmers who originally stole it and then redistributing it to Black citizens. So sort of combining all of these elements into your research justice portfolio is kind of how we are trying to go about doing anti-racist work and research. So I guess I'll stop there, and we've got a little more than 15 minutes for discussion. If there's any questions or discussion afterwards, feel free to email me there. And if you want to interact on Twitter, my it's underscore. My handle is Real Ironist, and that comes from the book.
Eugene, thank you. Wow, very provocative. We have time now to have some discussion. If you have specific questions, please put it in the Q&A section at the bottom of your screen. We do have one question. Can you give it, Peter Ulrich, can you give examples of the backlash you received regarding your reparations article?
Yes. So it was clearly a lot of this sort of right-wing culture war stuff, like, stop the steal, and I'm not going to get, anti-vaxxers and whatnot. But a lot of it was, I can just think of one on the top of my head. You, sir, are a fucking moron. How is it possible you have a Harvard professorship? There is, you'll peel the gun from my cold, dead hand before I ever pay for something that happened 300 years ago. And there were a lot along the lines of that I think the main understanding was that there's no, even Mitch McConnell said this, right? It's like, there's no connection between the racism that is happening today, the killing, the murder of George Floyd. There's no connection between that and legacies that start with slavery, then Jim Crow, then redlining, then, unfair credit markets, all, interpersonal racism. And so you could say that, okay, then that's where the dialogue needs to go. It needs to get people to understand these sort of socio-historical connections. But I think my experience with this was that, and I'm a real structural person, I don't think the dialogue part is ever going to work. I think you actually have to have equity for dialogue to work. And so, this then, evolves into, well, what is your political position? And I really only think through a socialist government and reparations being enacted, and then there is a House resolution for reparations. I only think after those things, would we ever get past where those emails would be flying, where people would be, committing the hate crimes that are going rampant in the U.S. And so all of it leads to political positions that you need to hold. And even if you take it farther, this always comes up. It's like, if you take it farther then to global health equities, well, then do you mean there needs to be global socialism? And like, yes, a lot of this ends up in sort of Trotskyite recommendations, but we won't go there here.
I have a question. So, we looked very closely at our hospital outcomes by race and gender and age and everything. And for the most part, compared to the whole city of Chicago, we didn't really see much of a difference, especially in the first couple of cuts. And it's not like everyone's, oh, Northwestern just has a lot of money, but the same was true at the University of Chicago hospitals. And actually our database, our patient population, it's a very heterogeneous group of people. There's people on public aid and there's people with a lot of money. It's kind of the whole bag. But the rest of the city, of course, is reporting, all the statistics that you're talking about. The Blacks have 2-4 times, complication rates and mortality rates and whatever. I just thought that was interesting when we first looked at our cuts.
Yeah, I think that might be explained by, so we theorized back in April of last year, so 14, 15 months ago, that the idea that there was this Black fragility and it was mostly due to comorbidities was nonsense, that all of it, 95% of it is going to be in risk of infection. And I think that's played out. If you look at a lot of the VA data, they're showing something similar to what you're talking about, that actually the Black people admitted to the VAs were having better outcomes, but a lot higher percentage of them were being infected as far as just incidence. So I really think a lot of it is just explained in disproportionate incidence. And then in places where you have larger populations, you'll see the mortality come out, but that it's not really this fragility of bodies theory or extra comorbidities. And that's why Tony Fauci got slammed by the people I roll with when he said, oh, Blacks are dying because of the comorbidities. It's like, no, stop blaming it on the bodies. And then he came around to say it's all because of structural racism. And then we were like, okay, good, you're on board. Yeah, structural risk in infection. And that's what that paper is all about. It has nothing to do with increased mortality once you're infection. It's all about you have the risk structure of and it's not, you don't have the agency to change it, of your higher risk of getting infected.
And now he's 80 years old and has 3 bodyguards. Hey, we have another question here. Addressing historical structural inequalities plays a critical role in conducting anti-racist research. However, there are strong interpersonal components that undermine local expertise and limit the utility of research in many contexts. How can researchers be mindful of their own positionality when conducting research? Can you speak to how your work seeks to center researchers from marginalized backgrounds?
Right. So yeah, that's hard, and I think that you're absolutely right. What the sort of critical theorists of all this say is that you have to start with the kind of critical reflexivity. Like, where do you stand in all of this? And how does what you do contribute to the oppressive regime? And so I'd say, I think working with partners in health is one step. I don't think it's an end, because I envision, there shouldn't be a world where it's necessary that NGOs are going elsewhere to sort of bring charitable elements. But while we're in this mode of transitional justice where we get to a more reparative realm, PIH does good work of really partnering with local institutions, staying to build health systems instead of leaving right after the outbreak. You could see from if you look at the Sero Survey project, that is essentially from my K award, but The first author is a Sierra Leonean physician. All the rest of I mean, I think there might be only, 2 or 3 Americans on it. A lot of Africa CDC people. Like, I could have done this just as whatever, dropped in and done a Harvard study, and I pushed all that way. In fact, I was in the, what do we call it? I don't even remember the word of it. We got something like $110 million from some Chinese institution to run the Harvard, Massachusetts. They have an epi program, a pathology program. And I was in the epi one, and I dropped out after a day because I saw how kind of regional serving it was, and put all my resources in promoting how the Africa CDC, how Sierra Leone could examine their own outbreak. And so, the Africa CDC had this continental vision, right? They want to move past this NGO coupled with Ministry of Health doing localized stuff. They really want to enact a continental vision. So I went there, we developed a general protocol, we assisted all the kind of countries. So I think being very attentive to local empowerment, and using what resources you have for capacity building there, instead of, if you look at the results of, how aid and research money flows, right? It's like 90% still ends up paying for, American goods, or American, the technocrats going over, or lab equipment from the US. So really trying to get those resources into the local hands. And then I also think it's very important to kind of deconstruct our methodologies, right? To see how a lot of what we do, and I have examples of it in the book, kind of perpetuates, let's be like a neoliberal order. Like, there's good papers on how the Gates Foundation does this by protecting IP, by only supporting work that, thinks of the individual as this bounded rational agent, trying to deconstruct that stuff, I think, is just as important as the resource management, like really developing these kind of anti-colonial methodologies, like I tried to give examples of.
Another question here. How else do you ensure how do you ensure study participants are fully informed in the consenting process? Do you have any lessons learned in this regard that you could share?
Yeah, that's very hard, because a lot of the projects I've been involved in, you walk away from it. I think this is a lot of people's experience, that how could they have even understood that 10-pager? So I worked with the Prevail team. That's the NIH team that was doing Ebola research in Liberia. And I thought they, despite being, like corporatized and very top heavy, I thought they did a very good job, because they prioritized forming a social mobilization team that was all local, that always went to places beforehand and did a lot of, in-depth upfront work. Like I described, you don't just rock up to the village and talk to the town chief and then do the project that day. It takes, a week per village of just setting up with chiefs, really breaking bread, demonstrating the project to people. The other thing that Prevail did, they had a band. Like, they actually paid a band that made songs that had to do with the research projects, that would go and perform at each place to kind of get people interacting, and they play the songs on the radio. And so I think there are ways of promoting the social mobilization part that are important. But in the end, the thing I've seen that is the most important, and I've written about this in the book, that I think that research without a clinical delivery platform, to me, is a very unethical thing. So that if you're not using, and you can't really do this with NIH grants, right? So you got to figure out a way to get it with philanthropic money or whatnot. But we don't work in anywhere that we don't have sort of a PIH arm, that if someone comes in sick with anything, we can deliver care. We can, even people that aren't in the study, we can recommend that this is the kind of hospital setup we have nearby. That was one thing I noticed with Prevail. Despite their whatever $100 million that they started out with, we had a study participant come in who was sick, and they said, okay, well, you can't get your infusion today, and redeem that your sickness is not from your past infusion, so see you later. It's like, I don't have any money to go to the thing. And they said, walked him out the door. Like, not even like, here's $10 to do the thing. Not even, here's our center where you can refer to. And that to me is a huge, that to me is probably most research. And I think we need to move to, if you're going to be extracting academic capital, you have to have a clinical delivery platform associated with it. That's my opinion. That's my self-righteous opinion.
We learned that lesson the hard way in the HIV field when we
Yeah.
were all siloed doing HIV, and oh, you had a heart attack. That's not AIDS. Go away. A couple more questions, and then we're going to wrap it up. Dr. Richardson, you mentioned government positions and action. Is your team directly involved in any government actions?
You mean in Sierra Leone or in the US? I mean, I guess I could do both.
I would say in Sierra Leone.
Yeah, so this project was run through the Ministry of Health, through their emergency operations center. So you can see like the co-senior author is the head of that emergency operations center. So all of it was presented there before we even did anything. They give their input about how they wanted it done. They picked the team. They coordinated the resources that came from Africa CDC. So yes, this was all done under the auspices of that, COVID pillar. But then once the research was done, even before we put it to preprint, we set up the presentation to them, and we were really highlighting the fact that, look, you're getting 90 cases, it probably means 3,000. Containment right now is awful. And so we had a lot of going back and forth about, okay, how can we start to convince people that even though we're only putting 90 in the newspapers, this really means there's a lot more. You need to take your social distancing and masking seriously, because people aren't. They're like, 90 cases? I haven't seen anyone die not wearing a mask. And so we've been working very closely with them. In fact, that the whole idea was to sort of operationalize what I had from resources, the Africa CDC stuff, to do something that was helpful for their containment efforts. And I think it's worked out well as far as getting all the information, now getting the people to accept it and respond to it. That's the hard part.
Okay, last question, a little bit loaded one here. Reflecting on, I think you're used to this.
I like those, yeah.
Reflecting on your extracting the longstanding impacts of apartheid in South Africa on TB risk, have you seen any anti-racist, anti-apartheid research prospecting the impacts of the current structural violence upon Palestine?
Ooh.
Yeah, I told you.
Yeah.
Your last question, by the way.
So I have, colleagues doing that. We just had a resident who graduated from the Brigham in our global health equity program, Brigham Wispelwey, who's, goes back and forth and is trying to do that research. I mean, interestingly, I have colleagues there, and we were supposed to have a section on reparations for Palestine. And the woman who we asked to spearhead it said, this is a little off the record, but that this will destroy your Lancet report because of the PR machine that will attack you. Do it without it. And then once your report is out, you can use it as a springboard to do just a separate reparations study on Israel, on Israel-Palestine. So that's how much like the politics and the sort of public relations got into, what even determined what we were going to study. So the plan is, once this report is out this summer, we're going to have a big conference, because we only have 10 sections and there are thousands of reparations claims worldwide, to invite as many of those groups to the conference to use the report to help, strengthen claims. We're trying to raise money to seed some of this research, but we're also raising money to not only have kind of like academics in residence at our program, but advocates in residence. So people that are doing the, grassroots organizing, so that we can sort of transcend this ivory tower component of, what is the reparations report.
Well, Eugene, we're at the top of the hour, and I want to just thank you very much for taking the time to share your insights and expertise with us today. Thank everybody in the audience for joining us and submitting your thoughtful questions. I'm sorry we actually didn't get through all the questions, but Dr. Richardson has volunteered to take other questions. You can email him. And we invite you all to join us for the next installment of our Global Health First Friday seminar series. The next one will be in September. September 3rd, actually, our first Friday will feature a discussion with Benga Ogadegbe, Director of the Institute for Excellence in Health Equity at NYU. and registration information will be shared soon for you. So again, thank you very much for joining us today. For those of you who registered, a recording of the webinar will be shared by email shortly. And this concludes today's webinar. Thank you very much, Eugene. I really appreciate meeting you.
Thank you.
Thank you for your presentation. Thank you, everyone.